Good morning, everybody.
Good morning.
For those of you who don't know me, my name is Dr. Charles Adair, and this is Corrective Chiropractic, Neurology, and Functional Medicine Center. We've been here since 1999, so quite a few years. And so we started doing functional neurology, functional nutrition. After being in practice for about 10 years, we realized there was a lot of people that we were not getting excellent results with, mostly people who had fibromyalgia. So my partner, Dr. Childs, started investigating neurology, what's called functional neurology, and I started studying functional nutrition, functional blood chemistry analysis. And so what we were finding in these population of patients, there wasn't a very good outcomes with just traditional physical medicine. So we started doing nutrition and functional neurology, we were having better outcomes. But what we discovered, there was a common thread with people with fibromyalgia, is most of them had thyroid problems. Most of them had bad guts, most of them were autoimmune. So that just started to evolve our education process and learning curve until we developed where we are today. So welcome to the workshop, The Evolution of Functional Medicine. Now these are my bona fides. I'm a diplomat of the American Association of Integrative Medicine, chiropractor as well. So these are some of the courses that I've taken over the years to expand my knowledge within the functional nutrition, functional medicine world. What I'm going to share with you today is basically the evolution of how things have kind of changed over the years. What I've noticed is that there are some basic ones that have been around for decades. These are the old schoolers, all right? Adrenal dysregulation, single nutrient deficiencies, detoxification and chelation, and antimicrobial treatments. And so many people who enter into the functional medicine world, or they start to kind of drift into the internet world of internet warriors world, these are the ones that usually start with. So we'll go through the basics of these, and we're going to talk about today how some of the treatments for one area can be counterproductive in another. Right. We'll kind of break that down, and some of you may have been trying some of these treatments on your own or with a professional, and maybe you weren't happy with your results. Right. Then we're going to talk about the new generation, the next generation, leaky gut. I mean, that's a big topic on the internet, and it has huge implications for health and its ramifications with autoimmunity, malabsorption, and things like that. So we'll delve into leaky gut, and we'll talk about the mechanisms and implications and all those sort of things. Then there's immune system polarity. Right? What that means is Th1, Th2 dominance. Right? So about 10 years ago, this was kind of the newest of the treatments for autoimmunity. Basically, trying to guess which side of the immune system is overactive, which one's underactive, so that you could balance them. Right? And so that was kind of where we evolved in treating autoimmunity, was treating leaky gut and doing a lot of testing and so forth to see if a patient was Th1 or Th2 dominant. And we'll explain how that evolved and so forth. And then elimination diets. Right? A lot of information on the internet about this. Welcome. Please have a seat. Make yourself comfortable. And we'll go over the autoimmune paleo diet, the SIBO diet, all the diets for any particular condition, gluten-free, and all the implications of those. So these all have huge ramifications for helping people with a lot of different disorders, whether it be autoimmunity, infection, food intolerances, and so forth. So we'll talk about the different diets and how some diets for certain people won't be so good. For example, somebody who is reactive hypoglycemic doesn't do very well on a paleo diet. And then other people who try other diets for other reasons may have adverse reactions as well. So we'll go through why some of the diets have to be proceeded with caution in some cases. Then we're going to talk about the next generation of evolution. So this has come about really within the last few years. Attending a seminar in New York City next week on functional endocrinology. A lot of it has to do with oral tolerance and central immune tolerance. Central immune tolerance is what we evolved from immune system polarity. So instead of trying to guess which side's imbalanced and rebalance it, we're trying to say, okay, how can we support the immune system's tolerance so it balances itself instead of kind of doing some guesswork in that regard. So that's talking about how you get your immune system to behave. Right? Autoimmune dysregulation is when your body is misinterpreting or overreacting to the environment or to cell tissue or a combination therein. So central immune tolerance works on stabilizing the immune system so it's self-regulating, upregulating the T regulatory cells, downregulating the Th17 system, which is the inflammatory cascade. So we'll talk about central immune tolerance, and that's still a very strong arrow in the quiver of treating autoimmunity. Now, I was recently in a seminar, well, not really recently, about 9 months ago, where this newest evolution is coming online. It's called oral tolerance. So we talk about leaky gut, right? Leaky gut is the membrane, you know, it's the basement of your gut lining. But there's something called a mucosal layer. Right? So what we're finding is that, you know, we're working on fixing the zonulin and gluten networks in the membrane, but ignoring the mucosal layer, which has great implications in how you tolerate things you're exposed to. So we're talking about how the mucosal layer has implications in food sensitivities, infection, signaling systems, all those type of things. So we'll talk about not only the gut, but the mucosal layer, which is the lining of the mucous lining. Very, very important. It's new evolution is kind of coming online. Now, the next thing, and the last thing we'll talk about is genomics. Has anybody here had 23andMe?
A what?
The 23andMe test? So, does anybody know what a 23andMe test is? It's a genetic test.
Yeah. DNA test?
DNA test, exactly, yeah. It's a commercial, you see it on commercials all the time. You send a swab in and they analyze your DNA. They can do ancestry, they can do you know, certain things, but they also do medical. So what we can discover is what breakdowns in your genetics cause certain problems to occur in your health. They're called single nucleotide polymorphisms. So these are when your DNA strands are not shaped properly, and as a result will cause defects in your bodily processes, whether it be methylation, whether it be vitamin D, whether it be hormones, whether it be any number of things. We'll go over some of the most common SNPs. But what we're doing now is taking we can take your 23andMe report and scrub it for all the pertinent medical information, and then fine-tune your nutrition based on what we know you to be deficient in or inefficient. So in other words, you may not be able to break down B vitamins into their what's called methylated form, and as a result, you have problems with detoxification and inflammation. So we can identify which B vitamin you have the deficiency with, inefficiency I should say, and then support you with that methylated form. Right? You can do that with all sorts of things. Estrogens, B vitamins, D vitamins, any number of things can be identified on your genomics. So we'll go over genomics.
Could it also be for pharmaceutical products too?
Absolutely, yeah. So psychiatrists are now using this as well, yeah. And there's certain SNPs that make a person vulnerable to certain medications, having bad reactions. Yeah, so particularly psychoactive drugs, you know, SSRIs, things like that. You know.
Okay.
The MOA SNP makes somebody real, you know, they have bad reactions to certain dopamine support. Yeah, exactly. Yeah. And so we'll talk about genomics lastly. And then what I'm going to tie it in is basically how certain protocols within each paradigm have to be taken, you have to take into consideration implications if somebody has certain conditions, i.e. you may make them worse or they have an adverse reaction. All right. So with that, well, let's get started. Here's the key to all this. There's no single building block in functional medicine is the answer. So a lot of times when people start exploring functional medicine online, whatever they discover is usually what they get very interested in, and they want to do that treatment a lot. So you have to integrate them, right? and make sure that you're doing them in the proper order. And in functional medicine, there are certain pillars within your metabolism that are more important than others. Barrier systems and immune system dysregulation are the two most important things that need to be dealt with before you deal with infection, blood sugar problems, adrenal dysregulation, anemias, and all down the line. Because if you ignore those two, it undermines everything else in that pathway. So in functional medicine, we think in terms of pathways. So pathways in your metabolism, and things that show up on blood work as being out of range, or things that are causing problems symptomatically and so forth, are generally what get the most attention from a provider, whether it be functional or allopathic in that, for that matter. So you got a high TSH, you get a medication, the TSH goes down. You got high cholesterol, you get a medication that goes down. So you're intervening at the end stage of what is washed up on shore of your metabolism. All right. Functional medicine practitioner asks why. Why is that number out of range? And we look upstream within the metabolism to see where we can intervene to improve that outcome. Right? So that downstream, the outlier starts to resolve itself. Now, what we discover over time in working with a patient is what can't fix itself. And then what does need support, either in the form of medicine or nutrition, for their particular weakness. Right? And so the end stage intervention has its place, as does the upstream intervention as well. Both have their advantages. Both, functional medicine gets at the root cause and tries to improve and maximize your efficiency, whereas allopathic is going to make up for the deficiencies at the end stage. And sometimes you need that because you can't do it anymore. You don't have a thyroid gland anymore, you know, or whatever it may be. Okay? So I'm not saying one is wrong, one is right, but the functional approach works downstream versus at end stage. And so we'll talk about which building blocks are counterproductive to others. But the most important thing of functional medicine practitioner is really uncoupling vicious cycles. So if somebody has lost oral tolerance, they have leaky gut, they're autoimmune, they have latent infections, their liver is sluggish, their thyroid is sluggish. My job as a practitioner is to decide which is most important and how to unwind these vicious cycles slowly enough and in the proper order so as to not disrupt the other issues within the body. Right? So we'll start with the basic presentation, but basically that's it in a nutshell there. Having the big picture so that you can start to unravel these vicious cycles. So the first thing we'll talk about today is the adrenals, all right? So the adrenal cortisol release is modulated by the HPA axis. All right, so how much cortisol does your adrenal gland produce? Hippocampal modulation of the cortisol rhythm, all right? This has to do with your sleep cycle, circadian rhythm. Right? So at certain times during the day, it should be very low, and certain times it should be very high. Right? So we'll talk about that rhythm there. Pineal modulation of melatonin. Right? Melatonin has an inverse relationship with cortisol. Melatonin goes up, cortisol goes down. That's supposed to happen at night within the circadian rhythm. Right? So they should have an inverse relationship. So if the melatonin through the pineal gland is altered, or somebody's taking melatonin, they can really disrupt their cortisol rhythms. And then Mizzen cephalic modulation of the autonomics. That's a very fancy term for stress. All right. The mesencephalon is the gateway within your brainstem for stress. Right? So when your brain says fight or flight, it fires down to the mesencephalon, from the mesencephalon through the autonomic sympathetic nervous system to the adrenal glands, which creates adrenaline, cortisol, and things like that. So if the gateway is faulty, in other words, you have a fatigued mesencephalon from being chronically stressed, chronically tired, chronically inflamed, then you're not going to gate the sympathetic release of fight or flight response to the autonomic nervous system. So you're constantly have a fire alarm going off, And what happens is it's still firing, but the alarm just gets sluggish, and you have chronic irritation of the sympathetic nervous system. So the adrenals get dysregulated and fatigue, things like that. Now, how to evaluate the adrenal system is to first monitor circadian rhythm symptoms. You have trouble getting sleep, staying asleep, slow starter in the morning, late afternoon fatigue, afternoon headaches, and we'll go over some more of those symptoms there. Those are signs of adrenal symptomology. Adrenal salivary index, so it's commonly called the ASI. So you take a cortisol, a saliva sample at 4 different times during the day, and you measure the amount of cortisol versus where we know it should be, and we get your rhythm. So we get quantity and quality, rhythm and production. And then assess neurotransmitter function. Does a person have deficiency of GABA, which prevents anxiety? So are they constantly anxious? Is it constantly firing down the sympathetic nervous system? And so forth. So here are some of the symptoms. Can't fall asleep, can't stay asleep, slow starter, so on and so forth. Right? Blood sugar symptoms are a big sign that you're having some adrenal dysregulation, because cortisol's job is to bring stored glucose out of storage and put it into the bloodstream. Right? So when you're in your fight or flight response, your body's saying, well, you're going to need some fuel for those muscles so you run away from this tiger or whatever it may be. Right? So when you've been sleeping all night, you haven't eaten for 8 or so hours, maybe 12, your sugar starts to dip. Your brain says, I need fuel. It wakes up the adrenals, cortisol comes out, and blood sugar feeds the brain. Right? So that's what's supposed to happen in the morning. Right? And then it's supposed to go very low at night, and so forth. Right? So there's the adrenal salivary index. That's a home kit. You take it home, you take the samples, you mail it in. It comes back in about 10 days. And we get this report. It shows 4 different times where you are versus where you should be. And it gives a total, which is not very visible right now, sorry. But that basically gives us your circadian rhythm. Right? And the rhythm and quantity of your cortisol output. Very useful tool in the evaluation of the adrenals. So we mentioned GABA. And so these are the 4 primary neurotransmitters. There's others, but GABA is one of the most important when it comes to the adrenal system because, again, it slows down this fight or flight response. It keeps you calm, relaxed, and so forth. It's the brakes of the brain. Right? So if you have a deficiency of GABA, you tend to get anxious, anxiety, nervous, emotional, irritable, things like that. Right? Which causes autonomics to fire, the sympathetic nervous system, into the adrenal gland, producing fight or flight chemicals. Right? But serotonin can be deficient, and that disrupts your sleep cycle. Dopamine can be deficient. You get a lot of cravings, a lot of sugar cravings when you're dopamine deficient, and or your adrenals are dysregulated at the same time. A lot of sugar cravings, a lot of stimulant cravings when you're dopamine deficient there. And acetylcholine, if you have, forget why you walked into a room, poor short-term memory, things like that, is generally acetylcholine related deficiency. But all of them have implications and interact within the adrenal system. And so we talked about the autonomic nervous system. So this nerve right here, this long one that goes down here, and you can see it connects to all these guys here. That's called your vagus nerve. There's that mesencephalon I talked about. That's the gateway. Right? So somebody with a short fuse has no break on their mesencephalon. Up here is where the thought originates, and GABA is going to inhibit the anxious thought here. Then it can be gated at the mesencephalon, and then these yellow nerves are the sympathetic nervous system. And you can see they fire down to, where are we at there? In the adrenal glands right there. Right? So the vagus nerve has huge implications in proper adrenal function because the vagus nerve is what we call the feeding and breeding nerve. Right? It's the peristaltic rhythm. So it has an inverse relationship with the sympathetic nervous system. When you get nervous emotional, it downregulates its activity, while the vagus nerve goes slower as the sympathetics go higher. So it screws up your digestive rhythms. Right? That's why you get a tummy ache when you're nervous. Alright, so how do we break the cycle? Alright, so the most important thing is to reestablish the sleeping pattern. You cannot fix the adrenals if the person is not sleeping properly, meaning that they're getting to sleep and then they're staying asleep. This is where I always start. If somebody's not sleeping all right, there's no chance to restore the circadian rhythm. Can't do it. Right? So that's where we start, whether I'm supporting GABA or serotonin or whatever it may be, to reestablish that. That's the first thing we got to do. If we don't reestablish the circadian rhythm, the sleep patterns, the adrenals will never rest and recharge and then be fired up again. Now, adaptogens. You know, those your holy basil, your ashwagandha, you know, all the things that you'll read about as being supportive or helpful for the adrenal glands. Okay. And they are, and I use them. But they are not to be meant to be taken all the time, right, without addressing some underlying issues around the circadian rhythm. Right? But they are effective, and they do work. But they should. It's the reactive approach, not the proactive approach when you're using adaptogens. So they serve a purpose. Neurotransmitters we talked about, right? GABA support, serotonin support, dopamine support. And then if we take a step backwards, we say, well, how come there's a deficiency of GABA? Is there a SNP in their genetics? Is there an autoimmune reaction to tissue translocation so they can't make it? Or do they have a problem with the blood-brain barriers, inflammation in the brain that's affecting the function? So maybe we have to address those things as well. So in functional medicine, you always want to ask why and look upstream. Right? Upstream, we see the vagus nerve. So if somebody has chronic stress, can't sleep, I do a lot of vagal stimulation. So vagal stimulation can be through acupuncture and things like that. But we use something called auricular therapy, where we actually use an electrical probe that looks like a pen, and it gives a very minute electrical shock to the ear, and it fires into the mesencephalon, activating its activity, upregulating it. We also use something called somatosensory evoked potential, which is a two-pronged probe that we can place on the tongue, which fires up the mesencephalon. All right? So neurologically, we can fire up the filter in that brainstem for stress. So somebody who receives those therapies, I use it as what's called a differential diagnosis. So somebody presents with stress, IBS, irritable bowel, anxiety. At their first visit, I'll have them receive auricular therapy and SSEP. And I said, when you come back to go over your blood work, let me know how you slept and how you pooped. All right? And if it's better, then we know there's brainstem involvement. So then, do I support GABA? Do I support brainstem? I start to kind of unravel the vicious cycle here. And then the vagus nerve, like we were just talking about, that has implications in many disorders for sure. And that's we support that as well. So here's the big thing about adrenals. It's a reactive system. Right? And so it's rarely the cause of a problem, it's more the victim of the dysregulation upstream in the metabolism. And so adrenal treatments are just stabilizing the system, and as soon as you stop intervening, the dysregulation comes right back. So you have to ask, well, how long do I need to do this before it starts taking care of itself? And that's why you have to reestablish the sleeping patterns, look at the neurotransmitters, vagal stimulation, and all those things. Not just giving adaptogens every day, or not just smoking cigarettes every day, or not just drinking coffee every day. Caffeine, sugar, alcohol are all adrenal stimulants. So somebody who's got adrenal problems tends to want to have those stimulants. Right? So adaptogens are kind of doing the same thing. They're Band-Aids. Effective Band-Aids, but they are Band-Aids. Right? So when you get off that merry-go-round. Right? So again, that's where we have to unwind those cycles. Now, next thing I want to talk about, first of all, any questions on adrenals? No? Okay. So the next thing is single nutrient deficiencies. Anybody relate to this?
That's me.
So, this is usually where the amateur functional medicine aficionado starts. Because there's a list of symptoms caused by the deficiency of this nutrient. I must be deficient, let me take this. And pretty soon you've got 40 bottles that you're taking. And trust me, I've seen this person bring their bag into my office several times. And so when I first got into functional medicine, the very first lecture I went to is when they bring a bag with them, look out. Well, sure. And so there's any number of single nutrients that can be, a deficiency associated with a single nutrient can cause certain things, no doubt about it, right? Iron, vitamin D, B vitamins, any number of things. And there's obvious nutritional deficiencies you'd see in the third world that you can, like rickets and, marasmus and things like that. But it's uncommon for somebody to be so deficient in the naturalized, not third world country, to have a single nutrient deficiency. It can happen, but it's not as common as you think. And it's important to understand that there can be a breakdown along a complex metabolic pathway full of cofactors and precursors. Right? So there's a lot of factors that affect whether the nutrient is actually going to get into its bioactive form. Right? Because a lot of people take B vitamins, their blood serum, B12 is off the charts, but yet none of it's getting into their cell. So single nutrient deficiencies have to look at precursors and cofactors. Right? Here's the factors to consider about single nutrient deficiencies. Intake. All right, so are you taking enough? Right. And so, okay, well, how do you know if you need to take it? Right? And so, a lot of times people on the internet just go based on symptoms. They start taking things they think that's going to magically fix something. But the intake has to be then absorbed. It has to be broken down, transformed into its bioactive form. So this is where a lot of people get stuck. Right? And so blood testing is the easiest way to know if you are deficient in a nutrient. But not all nutrient testing is accurate. You can't, for example, serum and urine tests for neurotransmitters really doesn't have any correlation. But things like vitamin D, iron, B12, all those things can be tested for to see if they are deficient. The most common thing I do see is vitamin D being deficient, whether it be from lack of intake or, more importantly, absorption. Right? So you can take it, is your body going to absorb it? Right? So if you're taking an acid, most of the vitamins you're taking probably won't be absorbed very well, if at all. Right? So you need a certain pH within the gut for nutrients to be extracted, whether it be through your food or through a nutritional supplement. Hydrochloric acid is very important for B vitamins in particular, and proteins. So protein, B vitamins, and minerals need a lower pH, a higher acidity than fats and carbs and so forth. So if you have what's called hypochlorhydria, which is a fancy term for low stomach acid, you may not absorb it, you may be taking it, but not absorbing it very well, or transforming it into its methylated form, as it's called. And so that methylation is activation. So your body, certain things act on those nutrients to make them bioactive, right? And so the term methylation means when the B vitamin has become bioactive and ready to do its job. Some people have single nucleotide polymorphisms that make that inefficient. So they can take a ton of it, but they can't turn it into its methylated form. Methylcobalamin, tetrahydrofolate, P5P, are the activated forms of the three most important B vitamins in the methylation pathway. Methylation is detoxification and glutathione recycling. Right? So recycling, right? So you could take a nutrient like glutathione, and you could get an injection, you get IV, you can take it in transdermal or liposomal or whatever form it may be, and you may feel a boost for a while. You may feel energetic or less tired, but then it wears off. The reason it wears off is that it's not being recycled. Right? So there's two markers on blood work that I put a tremendous amount of value in. One is vitamin D, and one is homocysteine, particularly when it comes to autoimmunity. So in the functional world, the range for homocysteine is less than 7, is a good number. In the allopathic model, the laboratory model, it's 12 or 14 before it's out of the laboratory range. But the functional range is 7 or less, is where we want to see it. Homocysteine has within it something bad, metabolic waste, toxin, cancer cell, whatever it may be, and it needs to release this through the detoxification pathways through the liver and the feces and so forth. Inside of a homocysteine, you have SAMe, CoQ10, and glutathione. They are sequestered in there. So you need B6, B12, and folate to free those free radical squelchers back into circulation and then process the waste out of the body. So the recycling process is called methylation, but that happens with other nutrients as well. So you have to worry about if you're taking it or enough, are you absorbing enough, are you activating it, and then recycling it. So these things can be affected by your genetics. We talked about the single nucleotide polymorphisms. We're talking about the ones. Yes.
Activation and recycling, both are caused by methylation?
No, the recycling is the methylation.
So what's about activation?
Activation, well, yeah, the methylation does act on activation as well, yeah. And so activation is bringing it to its methylated form. And then the methylated form is then acting on the homocysteine. See? So taking the B vitamin from ingestion to its... Making it methylated is activation. And then have... You got it, yes, thank you. So we talked about genetics. We're going to talk about that last. We'll talk about the MTHFR, or the MTR, all the ones that are associated with methylation. But that is one of the big factors that we'll see. Most people who are autoimmune have methylation defects, we call them. So they can't recycle glutathione fast enough, or vitamin D levels, they can't maintain them. And those two things, the reason I put so much value in is that vitamin D is very important for differentiation between self and non-self. We'll talk about that in the autoimmunity section. And then homocysteine has an inverse relationship to free glutathione. Glutathione protects you against oxidation and damage to your cells. So if somebody has a lot of glutathione, good vitamin D, tends not to cross-react. We'll talk about what that means. And they tend to have less cellular breakdown, oxidation, which is basically aging or rusting. Right? Digestive health. So we talked about the hypochlorhydria. You have to have good, acidic, healthy digestion, a gut that's not leaky and has a great mucosal layer, right? In order for you to extract the nutrients, either from your food or from a supplement. Liver health. Liver health has a lot to do with the recycling process, detoxification process. It has a lot to do with what happens to the half-life of the supplement, or nutrient, I should say. And then your thyroid health affects the digestive health and the liver health. Right? So if you have a sluggish thyroid, you're in a functional medicine analysis of blood work. The things that show up first, if there's dysfunction, are gut absorption and liver metabolism. Not that your liver enzymes are off the charts and showing inflammation. We actually see markers that are low that give us a clue to that. Blood urea nitrogen is one of them. It's below 13. It tells us to investigate the liver metabolism. Right? Because BUN is created in the liver and cleared by the kidneys. So if it's high, that means your kidneys are irritated. If it's low, it means that your liver is not producing as fast as it should. So on the Chem Panel, we'll see the BUN, we'll see some GGT, the liver enzymes, all those things potentially at play. And we also see that the protein breakdown, so we look at the serum protein, we look at the albumin, the globulin, and we look at the minerals. If they're all functionally low, it means that the gut and the liver aren't working as fast as they should. usually upstream, you'll find a common denominator, which is the thyroid.
What did you say, it should be less than 13? Was it the?
No, well, with blood urine nitrogen, if it's less than 13, can indicate that your liver metabolism is sluggish.
Okay.
It's not an indicator, it tells us to investigate other symptomology. So then I look at what's called my metabolic assessment form, which is questions about the liver and the gallbladder. Itchy skin, dry skin, smelly sweat, bloating, a lot of things that are associated with liver dysfunction. Then I check them to correlate with that. So then I have what's called a pattern. Right? So when I do a functional blood chemistry analysis, I just don't look at one value. I look at the one value, how it relates to the ones that should be affected by. So I look at the TSH and I say, ooh, it's high. Then I look at the gut absorption and the liver metabolism. It's like, I'm starting to see a breakdown here. Then I look at their symptomology, I look at their medication, their diet, and then I come up with what's called a pattern. We've got symptoms, we've got markers. Let's figure out where we intervene here. Right. So that was just a marker that helps me investigate that.
So this thyroid, is it both the overactive and underactive? Or
Yeah,
just
sure. But in terms of slowing down the metabolism, it's hypothyroid. People who have hyperthyroid would have different problems. Absorption and their liver metabolism not being sluggish would not be associated with hyper as much as it would hypo. So in terms of mastering functional blood chemistry, there's a lot of things to take into account. And your CBC tells us a tremendous amount, both with red blood cells and white blood cells. Right? And I'll get into some of those. We do a lot of special testing, which I'll be getting into. Special testing that helps us work with autoimmunity. Liver function, acute phase reactant, CRP is acute phase reactant, ferritin is acute phase reactant. If those are high, we suspect infection or something acute, something recent, not chronic. We look at the protein absorption. We wanted to see it above 6.8 total protein. I mentioned the metabolic assessment form. It's a questionnaire that has different sections within it associated with different parts of your metabolism. Upper digestion, lower digestion, liver, gallbladder, thyroid, pituitary, adrenal, and so forth. So I use that form a lot in conjunction with blood chemistry panel. Right? So we look at all these things when we're coming up to analyzing functional blood chemistry. You have to look at everything, not just a single nutrient or particular marker. Now, the next thing we're going to talk about, first, any questions about the last section? Okay. So the next section of the basic tenets of functional medicine is detoxification and chelation. Has anybody attempted this on their own or with supervision? No? Okay. Well, that's probably...
what do you mean, has anybody attempted this on their own?
Did you go on a detox? Did you read about, oh, I'm going to do a liver cleanse, I'm going to do a colon cleanse, I'm going to do... Right. Yeah, so, and so that's one of them. Sometimes when people do that, they have adverse results, and so we're going to talk about why that may be now. So, detoxification and chelation. Detoxification is different than chelation. Chelation is using certain chemicals to leach out heavy metals and so forth. Whereas detoxification is supporting liver metabolism. They're similar, but they have different paradigms. So the big thing you want to understand about detoxification, there's two components. One is drainage. Right? Drainage is dislodging the toxin. Right? And so once you get dislodged the toxin, then you have a couple of issues to worry about. Right? One is drainage. Where does that thing go once it's dislodged? Right? And you also create a free radical wherever the toxin has been dislodged now. So you could have an oxidative stress on that receptor site from the toxin being removed. And so if something else wants to jump in there, that's potentially going to cause oxidative stress or cellular damage. Right? But the drainage is where it goes once it's dislodged, through the bloodstream, into the liver, out your urine and feces. So if your detoxification dislodgement is outpacing the drainage, you're going to have what's called a toxic ping pong. So it just gets redeposited. So you go on this detox and you dislodge a bunch of mercury. goes through the bloodstream, but there's a backlog in the liver and things are not moving along, you're constipated and things are not getting out of the system, then you get a redeposition. What can happen is that wherever that heavy metal or toxin was, finds a new place. Now, if it's a heavy metal, it's often very much attracted to an electromagnet, also known as the brain. And if it's in the bloodstream, you can create an immunoglobulin. So in other words, if you just have a molecule of mercury, it could be inert, may not be doing anything. Right? But when it gets dislodged into the bloodstream, here comes an immunoglobulin, your immune cell, right, attaches to it. Right? So now we're good. Next.
Okay.
What you have is an immunoglobulin complex. Your immune system is attached to it now. That's called an antibody toxin connection there. That will stimulate T cells to come out and attack that area. So if you create that immunoglobulin, it gets redeposited in your brain. Now you have autoimmune activity in and around that toxin now. So you could activate dormant diseases if you do a detox and you have a compromised detoxification pathway. In other words, how much elimination can you get with the dislodgement? Right. So a lot of people get these detox hangovers. It's often doesn't resolve itself very easily. Or you can activate an otherwise normal dormant autoimmune condition. So how do we assess toxicity? Load testing. Right? We can test urine, we can test hair, we can test blood. Or we can do antibody testing. So what's the difference? So what we're seeing here is the toxic load. I use the hair. I like to do hair first because it shows long-term exposure. All right. And then if it's there, then we decide whether we should do anything about it. Okay. First, we want to see if there's a load. Right? Then there's antibodies. Right? So I had a patient. He had peripheral neuropathy. All right. And he was a fisherman. He was a fishing guide. He had a charter business in Florida, 6 months out of the year, and he lived here 6 months out of the year. So he's developing peripheral neuropathy. He was concerned about his mercury load because he was eating so much fish and so forth, which is a legitimate concern. And so I did the hair test on him, and he was loaded with mercury. He was, had some other, heavy metals, not to the extent of the mercury. And so he was very eager to do chelation. But he had peripheral neuropathy, and I didn't want to give him MS, which could happen if I dislodge all that mercury and it gets redeposited in his brain. So I did this test on him. This isn't his test, but this is Array 11 from Cyrex Labs. Array 11 is their chemical immune reactivity screen. Right? So what is this? This is testing is if you have an antibody immune complex associated with these toxins, whether it be aflatoxin or bisphenol A or mixed heavy metals, mercury, all these things are on Array 11. And if there's antibodies against these, then we have an autoimmune problem. Right? Proceed with caution with any detoxification pathways. If you don't, then it may be safer to go ahead and do some chelation and so forth. But you have to have certain things in place to attempt chelation or detoxification. Right? You have to have very good liver pathway detoxification. You have to be very regular, good levels of vitamin D, and low homocysteine or ample amounts of glutathione. Right? Then it's safe to begin those pathways. So this is the test I use if somebody is, I'm suspecting that they have a load, but we want to see if their immune system is aware of it or not. Do we want to poke that cage, or do we want to let a sleeping dog lie? Right? So if it's inactive, we don't find any of this, or we do find that, we may just let it sit for a while and then worry about it later. So in my protocol, I take care of things that provoke your immune system. I do foods, I do infection, then I do heavy metals and toxins last. Unless I think they're a major cause, and then we jump in earlier. Right? So basically, you could turn that into that if you chelate or you detox first. All right? So again, autoimmune with a compromised elimination process could do more harm than good. Yeah, I did a 30-40 minute video that's on our website. So you just go to our main website and you can just click on detoxification. I go over kind of it in depth there if you want to explore that more. All right. Now, the next thing we're going to talk about is infection. Right. Yeast overgrowth, dysbiosis, parasites, Lyme, SIBO, biofilm. This is the second most common thing that people will read on the internet and think that they have. Right? And then they want to do some things to get rid of it. Right? So, there's two approaches. A lot of it's based on symptoms. So you're on the internet, you say, I have a geographic tongue. I have bad breath, I have skin problems, I have low-grade fever, I have fatigue and bloating. I must have an infection. Right? Or you can do it on blood testing. Right? So, the first place to look in any investigation is the CBC with differential. Right? That tells us if there's something activating your immune system. And I'll go over that, each marker on the CBC, what it relates to and what level, okay? Microscopic stool samples, we can do, send it in looking for the presence of yeast, bacteria, parasites, all those critters. We can also do an inventory of the probiotics. The urea breath test is very effective for looking for H. pylori or SIBO. We can do antibody testing. Right? So we're going to look to see if you have antibodies against a certain microbe, just to see if there's a reaction occurring, is there a presence there. Or we can do biofilm testing using Cyrex Array 2. Array 2 is the intestinal permeability panel. I'll be going over that in a little more detail a little bit later. So, markers on routine bloods. We look at your white blood cell count. If it's above 8 functionally, we think there's an acute infection occurring. If it's below 4, there may be a chronic. Now, one marker by itself doesn't tell us anything, but these are the patterns within the blood. The resting ratio of neutrophils to lymphocytes to eosinophils are about 60, 40, and 1. Neutrophils are white blood cells that kill bacteria. Lymphocytes kill viruses. Eosinophils are either an allergic reaction to pollens and things like that. Could be a parasite or it could be yeast. Monocytes are the Pac-Men. They clean up the cellular debris and dead soldiers and so forth. So if they're up, they may be in the recovery phase of infection. So you're clearing the debris field. And the debris field is very inflammatory. So if you have a lot of phagocytic activity, which is what the monocytes are, because of chronic infection, you're going to have a lot of extracellular inflammation chronically. Ferritin. Right? Ferritin is stored iron. Right? Ferritin is considered what's called an acute phase reactant. Right? When you have an infection, your body's going to hide iron in the liver, because bacteria love iron, to help them replicate. So we see your iron go high, and we see other markers. We say, maybe something goes on in your immune system. A certain form of vitamin D, it's called 1,25-OH vitamin D. Right? The stuff, the one you get on a regular blood test would be vitamin D3. This is activated hormonal version of vitamin D. When your body is fighting something and needs vitamin D, it turns it into this type of vitamin D to help with fighting the infection. So if you see it above 75, we suspect either an infection and in some cases autoimmunity. But I find it more common with active infection. And then CRP is elevated. That can be very common with acute infection as well. So if I see CRP, I see a CBC issue, I suspect, yeah, we have something either chronic or acute that needs to be dealt with. Now, this is Array 2 from Cyrex I mentioned just a few minutes ago. This is their intestinal permeability panel, the leaky gut panel, right? They test for 3 things: actomycin, zonulin and agglutinin, and lipopolysaccharides. So, the zonulin and the Cludin network is the stitches that hold your gut wall together. The actomyosin is the cell structure within the cell. That's your cytoskeleton. And then lipopolysaccharide is created by gram-negative bacteria. So they can hide in this slime, and it's a defense against our immune system. So lipopolysaccharide is biofilm. So it's fat and many sugars that are secreted by these bugs, and they live under them and within them. And there's all colonies, and there's all kind of crazy things going on in the biofilm community. So if we see biofilm, we definitely know there's something as setup shop. Extremely common in Lyme. Lyme is gram-negative bacteria, prodigious producer of biofilm. That's why it's so hard to kill. But there's a lot of other bacterial infections and some parasites that can do it as well. So if we see positive lipopolysaccharide, we're definitely thinking infection for sure. Zonulin Cludins, we got breakdown intercellular. For actomyosin, we have transcellular breakdown. But in terms of looking for infection, this is going to tell me if I've got a biofilm colony. Right, so you've been diagnosed. We see infection. Let's kill that sucker, right? Well, common functional treatments. Botanical extracts, wormwood, cat's claw, urzi, oregano, garlic, golden seal are Th1 supporters. They mean they activate your T cells. And T cells are your white blood cells, the killer cells that kill infections. Right? So you activate the T cells, you're upregulating Th1, right, to help with the killing of the cells. Immune boosters, colostrum, green tea, grapeseed extract, nogenol. These are Th2 support, your B cells, your antibody production. So one's identification, and one is killing. Right? So your B cells and T cells work together in what's called humoral and humoral reactions and T cell mediated reactions there. Then there's biofilm enzymes, pectinase, nattokinase, glucoamylase, monolaurin, or some kind it's called, goes by a brand name there. Those are enzymes that help break down the biofilm. So that it helps digest away the sugar and fat so that it is degraded and eliminated and exposing the underlying infection there. So we can use enzymes there as well. And all of them have their place and can be very effective, for sure. But wait, what if you're autoimmune? So we're getting back to autoimmune once again. These treatments can make your condition worse. Right? So remember, if you recall from the beginning, I talked about Th1 and Th2 balance. Th2 is your B cells, your humoral immunity, and Th1 is your T cells, your killer attack cells. So if you're already Th1 positive and it's creating Hashimoto's or lupus or rheumatoid arthritis, and you take botanicals, you upregulate even more, you're going to inflame your autoimmune condition. Right? So you have to proceed with caution when you're using botanicals. Or if you're using green tea extract and the other immune booster and you're Th2 dominant, you're also going to make it worse. You're going to amplify your production of antibodies. Right? So proceed with caution if you have a dysregulated immune system. Botanical treatments can be very provocative to an autoimmune condition because it creates what's called cross-reactivity. Your immune system, which I'll get into later, can mistake certain proteins for others and attack it by mistake, and that's what happens with autoimmunity. We'll get into that in more detail. But you can provoke increased cross-reactivity. Okay. So the best approach for underlying infection, if you're autoimmune, is to use an integrative approach using functional medicine treatments for the immune system dysregulation. To get the immune system to behave and not overreact and identify self from non-self. And then medical treatments for the infection, potentially. And so we try to use integrative approaches. We have doctors that we're starting to work with. It's not been easy, but there's some advances in testing that have allowed us to communicate better. Right. So this is Array 12, and you see I mentioned the Cyrex labs a lot. They're an excellent lab that's actually in Arizona, but we have an account with them. There's draw centers everywhere. Very high-end testing, very, very sophisticated. This is their Array 12. This came out the first of the year. And I've already had 2 or 3 cases that I've been able to crack, so to speak, because of this. Ones that I've just run into some very stubborn issues. Okay. So these are all the microbes that they test for. Some of them are bacteriums, some of them are viruses, some of them are yeast. And they tell us if there's either been a past infection in the equivocal range or potentially an active infection in the out of range. So I was working with a young girl, and she had a couple of autoimmune type conditions. She had a very swollen knee that she'd been to all the, the high-end pediatric hospitals and doctors, and she said they thought it was rheumatoid arthritis, but she had negative rheumatoid factor, but they call it non-specific autoimmune arthritis in her knee. Her knee was about double the size of the other one. She had some other issues with her eyes and skin issues. So I ran through my protocol. We did regular blood work. We identified some issues there. We cleaned those up. We did some heavy metal testing. She had cadmium. We did something safe and natural to get rid of the cadmium. We identified food reactions. We took those out of her diet. We got her methylation back on track. We worked on some leaky gut. Everything was falling into place, but yet she still wasn't feeling very well. Her knee was a little bit better. Her skin had cleared up, her eyes, irritation, but that knee was, only about 15% smaller. So I did this Array 12 on her, and we found streptococcal M protein. And on her CBC, all it showed was a 64 on her neutrophil. So I knew there was something. I suspected there was a bacterial provocation. Right? So we did this test. She went to her pediatrician. Right? Pediatrician read this and said, okay, I don't think she has it. Well, the mother said, can you do a swab? They swabbed her throat, cultured it, sure enough, she had strep. They put her in antibiotic, her knee shrunk, and she's doing great. Right? So that test allowed me to use an integrative approach with other specialists to get the job done. So that's the infection section. So now let's go in depth onto leaky gut. So this is kind of what I just showed you this picture. These are the zonulin included networks, right? These are the cytoskeleton, and those are what we call the brush border. Right? So leaky gut is when you have a microscopic breakdown in those connectors, either through the cell or between the cell. Now I mentioned biofilm, a lipopolysaccharide. It causes a certain type of leakiness, both in the brain barrier and in the gut barrier. The lipopolysaccharides will cause these connectors not to break, but they cause them to be rubbery. So they stretch apart so that particulate matter can get through, even though those strands aren't breaking. And they're studying lipopolysaccharides to help deliver certain drugs better to the brain, for Alzheimer's, things like that, because it opens the blood-brain barrier, which isn't a good thing. Right? We don't want a patent. You don't want to open blood-brain or gut barrier. Right? So this is what we're seeing here, is the breakdown of the zonulin network. What happens is that proteins that you ingest are not being broken down into their smaller amino acids form, so that they can freely pass through and get into the bloodstream and be ignored by the circulating B cells, your antibodies. Right? So antibodies are keyed into proteins that don't match the inventory of self-tissue that your immune system says, this is us, this isn't us. Right? So your immune system is attracted to rapidly replicating things and proteins that don't match. Right? So they see a protein that doesn't match because the person has hypochlorhydria, right? They don't have enough acid, so the protein isn't being broken down. They have leaky gut, so that peptide, right? So a peptide is a small chain of amino acids, not a full protein. A peptide can now get into the bloodstream, where the peptide now looks unfamiliar to your B cell, it attaches to it, you have an immunoglobulin complex. If you get enough of those immunoglobulin complexes from frequent exposure to that protein, so you eat this food a lot, you're not breaking it down, you're getting a lot of presentation, you're getting a lot of B cell activity, immunoglobulin are created, the load gets to a certain amount, and then you have an inflammatory cascade kicks in because the T cells are coming to kick the butt of that, what they think is an invading organism. So that can happen with foods, and that's primarily why we test for leaky gut. But it can happen with infection as well. So you can allow microbes into the system that normally couldn't penetrate if you had a healthy gut barrier. So leaky gut is very, very important to deal with. I mentioned right away from the top that barrier system integrity and immune modulation are the two most important things in function in your health. So we have to assess the barrier system. If the gut is not healthy, the rest of the body cannot be healthy. It starts in the gut. Right? Now, we're talking about the basement layer here. We're going to talk about the mucosal layer later. Right? So leaky gut can be evaluated with the rate 2 that we just went over. How you fix leaky gut is elimination diets and certain nutrients to support that. Right? And that's part of unwinding the vicious cycles, determining is the leaky gut a bigger problem than the oral tolerance issue, or is the immune dysregulation? Where do we start, and how do we approach this? Now, this slide is going to be going over immune system polarity. Right? So when I first got into functional medicine, it was all the rage. Are you Th1 dominant? Are you Th2 dominant? Right? We know in general that certain diseases are Th2 dominant, certain diseases are Th1 dominant. We had challenge packs where we'd give you things that support Th1 or Th2 to see if you felt better or not. The problem is, you may feel worse if you guess wrong, And so you would irritate some people's autoimmunity by challenging them and then supporting the wrong side when it's Th1 or Th2. Right? So, so you can see some certain things are associated with autoimmunity with certain types of dysregulation. Right? So the Th1 is your T cells, Th2 is your B cells. Humoral immunity versus cellular immunity. Right? So it should be an equal balance. So if one gets higher than the other, you can have autoimmune issues, and in some cases cancers associated with Th2 dominance. But what immune modulation is basically, does it go up and down appropriately when it's being challenged and it's responding? So it's balanced. It may tip, but it's going to tip right on back. Now, certain autoimmune diseases are activated at seminal events in a person's health. Puberty, perimenopause, post-pregnancy cause a shift in the polarity so that you either can carry the baby without developing antibodies to it, and then it's delivered and it swings way on back and overreacts. So many people develop autoimmune disease after their, sometimes second kid usually, sometimes the first. Sometimes it's when they had their first menstruation. Sometimes they're starting to go into menopause. Sometimes it's a wicked infection or a trauma or something will cause a polarity shift. And then you get activation within the immune system that creates an autoimmune disease. So back in the old days, we would try to balance this by tipping the scales. And so we would add certain Th1 stimulators like we talked about, the botanicals. We'd give some botanicals, okay, let's bring up Th1 to down-regulate Th2, which is just a balancing act. We tried to do it with blood tests, we tried to do it with all kinds of things, and no one ever really was comfortable with the results of blood tests, and the challenging has its downfalls as well. So we've gotten away from doing the polarity, right? But basically, we're trying to increase the modulation on its own, and I'll get into that. So immune system polarity was one of the paradigms we used to use, not so much anymore. Right? So that's a balanced immune system. Th1 is the cellular, Th2 is the humoral. So if you're getting a blood test to look for antibodies, you're testing B cells. Right? Do you have antibodies against a protein, whether it be a food, a bug, or right? So that's what the polarity of your immune system indicates. Now let's talk about elimination diets. Right? So what we're finding is with any elimination diet, there's a honeymoon period. Because if you are eating a certain way for a certain amount of time, you develop certain tendencies and may develop reactions to certain foods. And so let me go over the different ones, and the ones I'm familiar with using clinically. Right? So the ketogenic diet is, basically the Atkins diet. It's, high protein, high fat, low carb, which can help you lose weight and help somebody who's really insulin resistant and so forth. And it has its place, but it's also what we call the cancer diet. If you eat that way forever, you're going to develop cancer. But for short periods of time, it's effective for somebody who is insulin resistant, has metabolic syndrome. You really got to just clean out their blood sugars and things like that. So it has its place. The paleo diet, which is kind of similar in that it's low carb, but it's really low grain. And so the paleo diet is basically no grains and more vegetables, low glycemic fruits, and protein. For autoimmunity, it's an excellent diet, right? And I use it a lot for about 6 months. My process for an autoimmune patient is determined first if I need to do gut repair, I need to do barrier systems, do I need to do mucosal layer, or do I need to do immune modulation, or a combination of the three. Somebody who's lost mucosal layer is sensitive to everything. Everything comes back positive on their test. So where do you start? You start with barrier systems, mucosal layer, to just get some tolerance. And we just eliminate the most offensive foods. Or if they don't have loss of mucosal layer, but they have breakdown in the gut, then we remove grains and lectins and beans and nuts and things like that. But the paleo diet is very effective for autoimmune conditions because things that are eliminated are most associated with causing leaky gut, causing immune system activation, and cross-reactivity. So we're talking about your grains, your corn, your rice, your gluten, your oats, things like that, or your exotic grains like your hemp and teff and quinoa and tapioca and things like that. So when somebody's autoimmune, and I think they may be a good candidate for a paleo diet, I just don't say, okay, here's a paleo diet, follow that. I said, no, let's start with this. Let's do some blood tests to see what food you're actually reacting to. So I order array 2. So if they have leaky gut, I know grains have to come out for a while because they are lectinous, meaning that they cause irritation and breakdown in the gut. A lectin is a structure that attaches to receptor sites and blocks absorption and irritates the gut. So grains are lectins, beans are lectins, nuts are lectins. Lectins are basically that seed trying to make it through the bird's digestive tract out into the soil so you can grow a new plant. It's their survival mechanism. It's enzyme inhibitors, they're called. Right? So our enzymes are inhibited by the lectins, and they stick to our gut lining, and they cause blockages of absorption, they cause irritation or dislodge, things like that. So my protocol for an autoimmune patient, who I think is going to be a good candidate for the paleo diet, is to do array 2, see if they have leaky gut. And I do array 4 from Cyrex. It's called our cross-reactivity panel. Cross-reactivity panel tests for foods that are cross-reactive to gluten. So usually we'll find out if somebody's gluten, they know that, or we'll test for it. Cross-reactive panel tests for foods that are cross-reactive to gluten. Dairy, corn, rice, oats, yeast, instant coffee, believe it or not, is cross-reactive to gluten. So there's the protein structure within that protein is such, the amino acid sequence, is that your immune system can mistake those foods for each other. Now, gluten is cross-reactive to thyroid. So if somebody goes on a gluten-free diet, but they're still eating corn or rice or oats, which they are reacting to, then they're really not going to receive much benefit from being gluten-free. And only about 40% of people who go gluten-free feel better. And the most likely reason is that they're still eating a cross-reacting food. So I look at the cross-reacting foods, and we strategically eliminate those. On that cross-reactive panel, they also have 18 foods that are commonly eaten on the gluten-free diet. So the hemp, the aromat, the quinoa, the teff, the tapioca, the aromat, the quinoa, all the foods you're saying, oh, I'm going to eat gluten-free. And then you just load up on grains. So you're jumping out of the frying pan potentially into the fire. There. So array 2 and array 4, and I use strategically a paleo diet. Very strict for about 4 to 6 weeks, and then we start adding foods back slowly. Because what we know is if you eat the same foods all the time, eventually you can develop sensitivities to anything you're eating if you have gut breakdown or loss of mucosal layer. Vegetarian diets. Right? Now, there's different forms of vegetarians. There's vegetarians who eat vegetables, and then there's vegetarians who eat Doritos. So if you're a Doritotarian, as I call them, you're going to develop leaky gut. You're going to have autoimmunity, and you're going to be anemic and most likely hypoglycemic. Because if you're just eating grains, it's going to break down your gut, you're going to develop antibodies, and you're going to get... I see a high percentage of autoimmune who, unfortunately, were Doritotarians or were vegetarians. Now, vegan is more a healthy version of that, but still, sometimes you see gut breakdown associated with grain consumption, which leads to gut breakdown and autoimmunity flourishes. Mediterranean diet is just a very good diet in general, but there's all those special diets can be good at certain times. What I find is that somebody who is reactive hypoglycemic goes on a paleo or low carb diet, they go crazy, they crash, they're irritable, they can't function, they can't think straight, because they can't store glucose and extract it very well to run their body, particularly their brain. So if I see somebody who has LDH below 140 on blood work, that means that they have a tendency to dip low if they don't eat. If I see their hemoglobin A1C is low, their resting glucose is low, their triglycerides are low, they get irritable if they miss meals, they get shaky if they miss meals. You know, I'm going to try and put some dense carbs in every meal and not go strict proteining and make sure they're getting some dense carbohydrates. That person doesn't want to snack on a fruit either. So they can't skip meals, they can't eat pure carb as a snack, and they have to eat every few hours to manage that part of it. Right? Or if you go on one of these diets, you'll just go crazy, you'll crash. You can't think straight, you can't do anything. Right? So certain diets for certain conditions have to be taken into account. Right? So those are the elimination diets. The one I find most useful in autoimmunity is paleo diet. But when it comes to loss of oral tolerance and the mucosal layer, a varied high vegetable diet is important. Right? The reason, you can hold, no, you just leave it for now, thanks. Grains, and more importantly fiber, from starches, is important in the development of certain fatty acids that are protective against food sensitivities. So if you go and you eliminate a lot of starches, you could potentially not be producing things, because bacteria, the good bacteria, feed on those starches to produce certain things that are protective to our gut lining. So we'll move with that. Right. So we talked about immune system polarity. Immune system polarity is the way we used to do it. This is the way we do it now. This is central immune tolerance. Central immune tolerance means that you're going to stimulate Th3 receptors. These are what we call the immune regulatory cells. They're T-reg cells. So T-regulatory cells will do two things. They'll inhibit Th17, which is the chemical reaction that ignites the inflammatory cascade. So if you're downregulating Th17 and you upregulate Th3, Th3 also helps balance Th1 and Th2. So the things that help upregulate Th3 are vitamin D, glutathione, immune modulators like curcumin and turmeric and things in that class. Right? So what we found is if we fix the gut barrier and we upregulate Th3, downregulate Th17, then we can rebalance the immune system to behave properly without having to guess which side the polarity is on. So that is a combination of elimination diet, gut repair, and immune modulating supplementation. So that's the new central immune tolerance model. Right? That's why I like vitamin D. Between 80 and 100 for somebody who's autoimmune, between 60 and 80 for somebody who's not, to prevent autoimmunity. And I want their homocysteine below 7. If I get those two markers in line, I've seen a very consistent pattern throughout the years that antibodies just disappear. They go, they expire. So we test you antibodies for your thyroid or for rheumatoid arthritis or lupus or whatever it may be, and we see a certain number. If you have your immune modulation back and you have your gut barrier integrity restored, and you've eliminated the most virulent inflammatory foods, you've cleared up some infection, you may be detoxified, you keep your vitamin D and your glutathione levels up, then your immune system just calms down and the autoimmune dysregulation just becomes dormant. Never goes away, but it just becomes silent, or in remission, so to speak. So we work on the glutathione recycling systems, the barrier systems, and the immune modulators. So that's the new model that's been very effective since we progressed out of the Polarity. Now let's talk about the mucosal layer. Right, so gut barrier integrity and or leaky gut gets a lot of attention, and we're doing a lot of good things in that regard. But what we're discovering is that the mucosal layer, which is on top of that, is just as important, if not more important. This is what we call oral tolerance. Oral tolerance is basically when you ingest something, what does your body do with it? All right? So if you have the breakdown of the mucosal layer, anything you eat becomes reactive after a while, or you're reactive to chemicals and perfumes. And so we call this toxicant-induced loss of tolerance, meaning that whatever you're exposed to is now provoking your immune system. So a breakdown in the mucosal layer is important, is a huge factor in that regard. So how we fix the mucosal layer is digestive enzymes. Right? So if you're not breaking your food down, you have to get those proteins broken down so that they don't provoke the immune response. Right? Short-chain fatty acids, butyric acid. Right? Butyric acid is what's created by the bacteria in your gut, the good ones, eating starches, producing butyric acid. Butyric acid is like suntan lotion. You know, it's going to soothe the burn, so to speak. So that's why somebody who's on a gut repair diet and autoimmune may heal their gut, but their mucosal layer may suffer. Right? So short-chain fatty acids, butyric acid in particular. So if I have somebody on an autoimmune diet, I give them the butyric acid. I need to take the starches away because they have leaky gut, or they're reactive to it. So we put butyric acid in its place to make sure that we maintain oral tolerance. Probiotics. So we talked about the good, healthy bacteria feeding on things we eat to produce butyric acid and other things that help calm the gut lining. Right? And then vitamin A, very, very important, we're discovering in oral tolerance. So we'll use some supplementation on that. And it all comes down to what's called salivary or secretory IgA. IgA basically is going to sample the protein, and it's going to bring it to a patch of cells in the gut lining and say, is this friend or foe? And they give it up or down. Right? If it's down, then it's inflammatory and it gets attacked. If it's not, then it gets processed through. It sends a little sample into the liver, say, okay, what do you think of this? And it's fine, and then boom, the food is accepted or tolerated. Or if it's not, then you develop antibodies to it, and there's an inflammatory reaction against that food. So the mucosal layer is responsible for the first line of interaction. People who have reflux and or on antacids have a broken down mucosal layer. Because the mucosal layer also protects you against the digestive juices of our own body. So if you have a thinned and worn out mucosal layer, you can easily get burned. So by restoring the mucosal layer, you can get off of that stuff eventually. Now, the mucosal layer is also going to be thinned by having hypothyroid and other conditions. But the upshot of what we're finding is that you have to have adequate vitamin A, good probiotics, good butyric acid, and breaking your food down to have a lack of hyperactivity or sensitization to that. So oral tolerance is moving right in next to gut repair in terms of autoimmunity and general health. Now, last but not least is genomics. Now, this is an explanation of some of the SNPs. Most people are aware of MTHFR. it's one of the most common and the one that causes a lot of problems. This is why they give moms folate and make sure the baby's healthy and so forth. That has to do with folate, all right? As does this one. There's two different types of SNPs. Now, a SNP can be heterozygous or homozygous. Heterozygous means you have one gene from one parent. It's weaker of a deficiency. Where homozygous, you have one from each parent. That's a strong dysfunction. Right? So it's going to be it's going to be worse. Now, just the presence of them does not mean they've been activated. Right? So when a gene expresses itself, it's turned on, then the problems start. Right? So things that cause these genes to express themselves are oxidative stress. There's breakdowns in the DNA strand caused by inflammation, lack of glutathione, lack of vitamin D, lack of immune modulators, things like that, allow these genes to express themselves. Once they're activated, then the deficiency starts. So MTHFR means you have a problem reducing folate into its methylated form. MTR is B12 problem. CBS is a B6 problem. COMT, I think somebody asked me about medications. That's the one that psychiatrists will, one of them, that and the MOA, important for that. And so these are just a few of them. There's dozens of them. And so genomics has just recently come to the forefront. And I use a company called Pure Genomics. And so when somebody gets a 23andMe report, they get an email. It's hundreds of pages long. And you have to be a geneticist to be able to read it. Because they don't give you interpretation anymore. A couple of years ago, you can't, none of the supplement companies or anybody who provides healthcare information can give advice unless it's, I guess it's legalese or whatever it may be. So what this company I'm associated with does is basically we put a patient who has a 23andMe report in. They receive an email, they email it to Pure Genomics, and then I receive a chart of all their SNPs, color-coded through the heterozygous, homozygous, and non-reactive. From there, I can say, okay, here's where our problems are. And, I use it to fine-tune issues. And basically, with this, I can usually get those stubborn cases over the top. It's usually hidden infection or genomics that will allow me to crack the case, so to speak, and get somebody to the highest improvement that I can get them. So I use the genomics to use certain forms of the vitamins. And so, for example, COMT, they may need a different type of B12, not methylcobalamin, but adenylyl hydroxy B12, because the methylated form may process out their neurotransmitter too fast or whatever it may be. So this is really a big wave in all of medicine. You'll see this being able to study genomics in the treatment of cancer, in the treatment of a lot of chronic diseases, both in the functional medicine world and in the allopathic world. So basically, I think 23andMe, they anywhere from $99 to under $99. You get a treasure trove of information about your health. And it takes about 6 weeks to get the results back, but if somebody happens to have one of these, it really kind of just clarifies a lot of things that maybe, okay, that's why you have that. No, now I see. No, this is why you have that problem. Okay, well, that makes perfect sense. So genomics are the latest and greatest in terms of what we can use in both functional medicine and allopathic medicine as well. So basically, I've covered every subject that are the main paradigms in the evolution within functional medicine. The way I approach a case is basically, if somebody wants to, has an issue where they want to be evaluated, we have a consultation. I have them fill out certain, paperwork, as the metabolic assessment form and a history, and we talk about certain things. I look at their medication, their diet. I send them out for a functional blood chemistry analysis. So basically, a functional blood chemistry analysis is going to draw about 9 vials of blood. It's going to be very thorough. It's going to look under every corner and under every rock, and basically allow me to assess where you stand metabolically. From there, I can say, okay, here is where the breakdowns are occurring within your metabolism. Now, if I can answer why, then I can make recommendations on how to improve things. But sometimes you need to do some additional testing to figure that out. If you're autoimmune, we need to look at leaky gut and food sensitivities. If you're infected, we may need to do a 12 or stool testing. If your adrenals are all over the place, we may need to do an ASI test. Or if I suspect heavy metals, I might do a hair or blood for toxins. But I don't like to do a lot of shotgun testing until I know, okay, here's the biggest problem in your metabolism right here. Here's the second biggest. Let's work on these two first, and this is the information I need to do that. Once I get that information, I say, well, here's what you should eat, here's what you shouldn't, here's the nutrients for these particular problems. Let's work this plan for 8 weeks, and then let's retest the outliers and see where you stand. So I call that a cycle. It's basically 8 weeks. I also see patients at a 4-week interval for subset tests, starting food or introductions, and so forth. And I give my patients my email. We communicate in between those sort of things. So depending on what kind of dysfunctions we've had, determine how many cycles you may need. So if you're interested in getting that workup, you have an opportunity today. If you want to sign up on after lunch or before lunch, the fee will only be $40. It's normally $77 is our new patient fee. So if you're interested in going through an analysis and a workup, I invite you to see Virginia at the front to sign up and make your appointment today. In the meantime, what I'm going to do is set lunch out. I have to heat up a couple of things. So if you wanted to sign up, you can do that while I'm heating up the food. Or if you have questions, I'll be back in about 15 minutes after I get the food set out. I'll be happy to talk to you individually as well. Right? Before we break, any questions?